Good morning, good evening, good afternoon to everyone joining the EPI-WIN webinar today. We'll just give a few minutes for everyone to join. In the meantime, please introduce yourself on the chat and where you come from. As usual, I hope we have participants from all over the world. We'll just wait one more minute for everyone to join. Oh, wonderful. I can see that we have friends from Indonesia to Chile to Nigeria. So welcome everybody and well, good day to you wherever you are. Welcome to another EPI-WIN webinar. Today we will be talking about managing diphtheria, the new WHO clinical management guidelines. And we have here a very eminent panel. For those of you who are new to EPI-WIN, we strive to make the science and the knowledge for health emergencies accessible, relevant, and actionable for everyone. And the area of diphtheria is just one of them. We've had diphtheria outbreaks, and we've had a group based on responses from countries to develop clinical management guidelines. We're also very fortunate that we have today the Director of Country Readiness Strengthening, Dr. Nedret Emiroglu, uh, to join us. And I request Dr. Emiroglu to please welcome everyone. Over to you, Nedret.
Thank you very much, Priya, and good morning, good afternoon, good evening, everyone. It's great to see that the numbers are increasing, almost getting closer to 300, showing the interest to this webinar, which is on managing diphtheria, the new WHO clinical management guidelines. And I'd say that I regret that we have to do this webinar. Diphtheria being a vaccine preventable disease with great vaccine efficacy and huge drop in the cases worldwide, now facing global outbreaks is extremely disappointing. Of course, as you know, the most recent big diphtheria outbreak we have seen was in 1990s when former Soviet Union republics was resolved, and then it was a lot of historical reasons for that, and after that it has been always sporadic, and that's one of the reasons why actually, while we see the situation in immunization rates dropping in many areas, and particularly triggered a lot with the COVID-19 pandemic. Unfortunately, now we see many outbreaks, Nigeria, Guinea, and neighboring countries in 23 and continuing in 24. And again, another fact we see is that in many parts of the world, because of the rarity of the disease, many physicians don't even think of considering diphtheria. So they look for other reasons and trying to get the diagnosis. And unless we address the patient on time, and it is a disease with a high fatality. So we have to know, we have to get the symptoms right, we have to diagnose on time early, and be able to use the diphtheria antitoxin again, which is of limited supply because of the disease being seen much less. So I'm really proud that the clinical management team within WHO Health Emergencies Program led by Dr. Janet Dias, and has been working through many of you and through many of the networks to finalize the guidelines and for the clinicians in the management of diphtheria. So I think it's very timely and important because it provides the evidence-based recommendations also on the use of the diphtheria antitoxin, which is very important. And I'm happy to see so many highly specified and recognized, respected experts in the panel. So I'm welcoming all of you, particularly Steve from the Monash University. And Steve, it has been great to have you with us at WHO, and your contribution had been an asset. And at the same time, we have Professor Srinivas Murthy of the University of British Columbia, again, who has experience on responding to diphtheria outbreaks around the world. And I'm also honored to introduce you Professor Salma Ali Suwaid, who is the head of Department of Pediatrics at Murtala Mohammed Specialized Hospital in the Kano State, and he's the case manager for diphtheria outbreak. So sharing their experience and knowledge is going to be a huge asset. But at the same time, I think we really welcome you to pose your questions, concerns to the panel. And back to you, Priya, with my great appreciation and thanks.
Thank you very much, Nadret, for that welcome address. As the director of this department, all of this has been done under her leadership. So thank you very much. As she mentioned, we have an eminent team here with Dr. Janet Diaz, who's the lead for clinical management in the WHO Health Emergencies Program. We have Dr. Steve McLaughlin, who was responsible at WHO for developing these guidelines, and he's also a professor at Monash University, and he will shortly provide an overview of this session. Then we have Professor Srinivas Murthy, who is professor at the University of British Columbia and has extensive experience of diphtheria response, particularly in the 2019 outbreak in Cox's Bazar in the camps for the Rohingya refugees. And he was also the chair of the guidelines development group, and we'll talk about the key clinical recommendations. But from the ground, we were to have Dr. Salma Suwaid join us today to talk about the experiences of the West Africa outbreak of cholera and what she went through there. Unfortunately, due to unavoidable last-minute issues, she could not join us, but she very kindly sent us a video, and we will play that video where she shares her experience with us. But before I invite Steve, very quickly, we'd like to know who you are. So So please, if you could go to slido.com, write this code or scan this QR code very quickly and tell us two things. One, where you've come from, and secondly, whether you have had experience of working with diphtheria. Two questions. And I'll just share it for a minute out here, and then I'll stop sharing it. And I'll also put this on the chat so that you can have a look. And we'll share the results after Steve's presentation. Right, over to you, Steve. And Steve will provide us an overview of the diphtheria outbreaks and leading up to the clinical management guidelines.
Thanks very much. Can you see my screen okay? Does it come across? Great. Thanks everyone for attending. My name is Steve McLaughlin and I'm an infectious disease and intensive care specialist from Australia, who's just back in Australia actually this week, who's just spent the last year with the WHO, working and was very fortunate to work with, as was mentioned, Dr. Diaz and Dr. Nadret in the clinical management unit. And one of our roles with that is to look at the clinical incidents happening around the world and really to see where we can help. And as we will talk about today, there's been some terrible outbreaks of diphtheria over the last 18 months to 2 years, and ones previously before that as well, but really quite catastrophic over the last year. And what became clear when we looked at that these outbreaks and the amazing clinical work that was being done in the field was that there was really a lack of guidance that was available and fit for purpose in that situation. And so the question was whether we could provide any assistance and help with that. So today I'm going to talk a little bit about just those outbreaks, and I'm not an epidemiologist, so obviously I've been helped by colleagues with some of this presentation, which is very generous of them. And then we have Dr. Salma, who's going to give an account of the front line, of what it was like to manage and be a senior clinician in the management of that outbreak. And Dr. Salma also was part of the guideline development group. And then Professor Murthy is also going to talk about his experience managing diphtheria and what the recommendations actually have changed to or have become, I guess, seeing it's a new guideline. So look, the interesting thing is we would all know diphtheria is, well, many diseases are old, but it's a disease that we thought we had sorted out as a global community. Back at the turn of the last century, there was some amazing work done. I think it may have been the first Nobel Prize was given to people that worked out around the toxoid and the vaccine. And it was really something that we used to hear stories about. There were still outbreaks around the world, but there was great hope that it was a disease, a horrible disease that we had potentially, as a world, been able to manage. There's slight variations around the world to vaccine protocols and what people should do, but pretty consistent. This is from the PAHO website. Really starting early in life with a vaccine. The diphtheria vaccine is obviously often part of, as you would know, trivalent or even pentavalent vaccine. And really it's a marker and used as a marker by people working on vaccine, as the global coverage of this vaccine sort of demonstrates how well we're doing as a community in terms of vaccination rates. And can we get to the 95% that is considered the standard we should be aiming for across the world to prevent these terrible and terrible diseases. As my other job obviously is in intensive care as well as infectious diseases, and it was always a moment of great grief when someone came in with one of these vaccine preventable diseases wherever I was working in the world, whether it was tetanus, diphtheria, pertussis, any of these diseases. And this is from one of our colleagues working in the field at the moment, from the amazing work that Medicine Sans Frontiers did, saying in a paper that was published in the Lancet just last year when he was interviewed, that this is talking about a disease that really should have been confined to history, that is now raging in West Africa. So this was happening started in, as was mentioned, early 2023, sorry, and continued and got worse over the year, as we'll show. So why did these things happen in the last couple of years? I don't think any of us will be in any doubt as to what happened. There is obviously, the world is fragile. There is many things happening in the world which we don't need to go into today, but obviously increase the fragility and the risk. But we had a global risk in 2020 and 2022 with the declaration of the COVID-19 pandemic. And really that meant vaccine challenges that were already there were exaggerated, made worse. And we really ended up with a situation where vaccine delivery was compromised, unfortunately. Again, a paper from Pakistan, actually not a region we're talking about particularly today, but thanks to these authors who have, this is published as a preproof at the moment in Journal of Infection, really demonstrating, and the words they've got there is this, their largest diphtheria outbreak on record was in the 27th of December 2023. So 912 cases with 124 deaths published recently from a region in Pakistan. And if you look into this article, you'll see that it's quite focal. It's clearly an outbreak type model where you can see areas of vaccinations where there's challenges. And then despite a countrywide vaccination rate that's reasonably high, in the regions that it dropped, unfortunately, cases of diphtheria occurring. So, as I mentioned before, it's really used as a global marker for immunisation coverage. And you'll see just in those figures, just from a WHO report, the number of kids that missed out on a vaccine, the zero-dose children, how that is, we're trying to inch that up. And that's an effort from thousands of people around the world to try and increase childhood vaccination. But you'll see how we've managed to do that a little bit. And really, that's the key over the next little while. Can we make sure that every child is vaccinated? I mean, as Srin, I'm sure, would attest, and Dr. Selma, ideally, we would have a guideline here that we've spent time on that never gets used. Would be the ideal case scenario in a few years' time, that diphtheria is confined to the annals as a vaccine-prevented disease. And just to give some context, so in the West African situation, which Dr. Selma will talk about soon, you'll see this, again, a number of DOMs that have come out from the World Health Organization. Just in late last year, situation in Guinea and situation in Nigeria, where you see literally hundreds to thousands of cases of diphtheria occurring in regions, a significant number of deaths and significant challenges in terms of delivering care to those people. These are all available from, publicly available from the Afro region, WHO office, where they've been publishing some excellent work around monthly updates as to what's been happening. You can look them up yourself. This is the one from February 2024, so just over a month ago. You'll see the total number of cases, very high numbers we're talking about in terms of number of cases. They really dwarf anything seen recently with the total number of cases in Nigeria. You'll see there on the left, suspected cases in the green. And we're talking thousands and thousands of cases. We're talking many, many deaths. Unfortunately, hundreds of deaths with this disease. And, these figures are relatively updated, but there are some obviously that need to be updated, and some countries that are having more cases as we speak. So clearly something that hasn't really been seen in the world for a very long time. This shows the epidemiology curve over the prolonged period. And you'll see, if you look back from this, it's sort of starting obviously from February, and it's a weekly chart. So you can see going back a year, and you can see really, as you get to around week 26, week 27 of this, you can see it really starting to escalate. This was the point that many people, and great thanks to the clinicians working in the area, MSF, WHO, and obviously the local clinicians in particular. And this is when the questions started to come through to many regional agencies, jurisdictional, and WHO about, do we have guidelines that are ready for diphtheria in an outbreak setting where there's large numbers of cases. So a number of the guidelines that did exist around the world of high quality, but we're really focused on what would be a small number of cases. Like, it's supposed to be an unusual disease, it's vaccine preventable. They weren't really fit for what do you do when there's literally hundreds of cases or thousands of cases in a region. And then you can see how just the slightly different timing of these various countries' outbreaks. You can see Nigeria, obviously the scale, just to let you know that the y-axis is different to the number of cases for each graph, but you can see the escalation in Nigeria with sort of a low number of cases for quite a long period, but a significant number of cases to the left of the graph for Nigeria, and then really escalating quite quickly towards the middle of last year, and taking a long time before that was able to be controlled. It's an infectious disease, obviously, with significant public health challenges as well, which Professor Murthy will talk about in terms of what we might do as the next phase of our guideline when we look at this. And just to give you some update about the regions, obviously an outbreak in infectious disease impacted by proximity of people living in the same house, going to the same school, things such as that. And you'll see the number of cases, and again, published, and thanks to the colleagues in AFRA who've produced this excellent summary every month. You'll see, not surprisingly, the vast majority of cases are in unvaccinated or unknown, obviously, and there's obviously a lot of literature around to suggest that the more severe cases tend to happen, obviously, in unvaccinated patients. So what the questions we started getting asked, and when I say we, I guess everybody was getting asked around the world as this started to happen, was, what do we do with antibiotics? There was some interesting data that came out of Nigeria and Guinea, which we can talk about, and Professor Murthy may touch on, about what is the resistance of antibiotics, diphtheria to antibiotics. Penicillin has been the classical recommendation, but there was data coming out of many countries, including Africa, that there was resistance to penicillin. Due to the availability of lab testing, it was a little bit unclear what that actually meant. And again, the lack of laboratory guidance in an outbreak setting of how do we actually tell how much is resistant, because you're not going to get the results back in real time. And obviously you need to treat diphtheria rapidly, as we'll talk about later on. So people were very concerned about what antibiotic do we give people when we're not going to have the ability to have the test back within a few hours. Obviously, it's going to take a couple of days, no matter what region of the world you're in. And when you've got thousands of cases, there's just really not the capability of testing that many people, plus the challenges of geography and availability. Then there was the question of diphtheria antitoxin, which we'll talk about as well. And that was about, who does get diphtheria antitoxin? How do you dose it? Do you do sensitivity testing? There's not enough diphtheria antitoxin. I'll talk about that in a minute. So, who is benefiting from giving diphtheria antitoxin, and what's the latest evidence for that? And then some things that we're still working on, which is how do you isolate people that have got diphtheria? How long should you isolate them for? Isolation, as we all know, we'll give probably a different answer to this question after COVID. We all know now the pluses and minuses of isolation and the impact it has on people, and also the resources that are required to where do you isolate people and how do you do it? And then how do you treat contacts? So those questions all came up in the middle of 2023. And so WHO has a very robust process for developing guidelines. What we were able to do in this situation, which is thanks to the efforts of many, many people, was do this relatively quickly. So while we'd all love to produce a guideline tomorrow when you're asked a difficult question, that isn't possible. But over a number of 3 or 4 months, we're able to go from a request to a published guideline, which is rapid for this sort of process. It involved over 20 people on a guidelines development group with experts representing all parts of the world, coming under together, the expert chairman of Prof. Murthy and colleagues from McMaster who do the methodology for us. And so we were able to produce this guideline rapidly, focusing on the first question 1 and question 2 really was our first focus, because we felt that was the thing that was the life-saving treatment. And that was able to be published early in 2024. Just a quick touch on diphtheria antitoxin. Really say it's been around for over 100 years. It's amazing if you ever want to read the story of how people came up with this idea. It's an amazing story of ingenuity when it was done. There was a lot of literature and things written from the first half of last century. There's actually not a lot of evidence past that around what was the optimal dose. People had worked out very quickly that it should be given early, and the earlier you give it, the better. And we can talk about why that is a bit later on, but we knew that early was good. We knew that you needed to give a dose that really wasn't weight dependent. It was disease severity dependent, but we really didn't know exactly how much or when. And so we needed to look into the evidence, and Prof will give you a talk later on about what we found when we went into the evidence, but we knew that we needed to have a good look, because when we looked back at where these guidelines had come from, and without being critical in any way, they were predominantly historical, based on things that had been worked out many years ago, and things had changed significantly. And what also was clear when we started looking into it, and we were hearing from our colleagues as well, essentially in West Africa, was there wasn't enough DAT. And it wasn't just the problems that we have all the time as a global community of making sure the right medicine gets to the right person, which we know is a problem in many diseases, but there actually was that problem, which was significant, but also there just wasn't enough. The world had confined diphtheria to a disease that was vaccine preventable, so there wasn't much being produced. It's a complicated process to produce it. And there was some great work done by colleagues at MSF, UNICEF, WHO, and many other places to collaborate to try and increase procurement of that and increase the supply, and then to try and get it as quickly as possible to patients that needed it. Which took a lot of people's time and effort, and it was time well spent to try and manage this life-saving treatment. That's all I was going to talk about today, and I really wanted to get onto the expertise of Dr. Suwaid, who was really one of the leads and will be introduced in a minute from West Africa, and then Professor Murthy, who's going to talk about what we actually came up with in our recommendations. Thanks very much for your time today.
Thanks very much, Steve, for providing an overview of diphtheria and how it led to the guidelines. And I request you next to play Dr. Salma's video. But just before we go that, I'd like to share the results of the Slido poll. So if you just give me a second. This is where all our participants have joined us from today, from Nigeria to India to the Netherlands, Mozambique, south of Syria, a wide number of countries. So thank you very much, and welcome. And I also want to quickly share with you where you've your expertise and your experience of working with diphtheria. So let me share that. Can you see my screen? No? Okay. So it looks like most of you have not worked in a diphtheria outbreak response. So what you learn today will be useful should you ever be in this situation. But a number of you are experienced, 38%. Wonderful. Just wanted to show you that. Now over to Steve, and could you please share what Dr. Salma has to say to us? Thank you.
No problem. I don't normally get nervous talking, but I'm more nervous about the technology working here. So we'll see if it works. Okay.
I'd like to actually also request all the participants to bear with us, because Dr. Salman was to be here with us in person and she was very keen to do that. But in the last minute, she couldn't. So this was she very kindly sent this video at the last minute, but we may have some technological issues. So bear with us. But over to Steve.
Yeah, just give me the thumbs up, Shrin, if this works.
Good morning, everyone. My name is Dr. Selma Adesway. I'm a consultant pediatrician and I'm the External State Case Manager for the diphtheria outbreak response. Kano State is located in the northern Nigeria. It's part of the West African region. The name of the hospital I work in is Murtala Mohammed Specialist Hospital. The diphtheria outbreak in Kano State started in December 2022, where we started seeing cluster of patients coming from a particular area that is known to have very low vaccination coverage. But as the time goes on, the outbreak was now seen it has gone to community level, and there were other key regions that were also affected. Most of the cases of diphtheria that were seen are usually from the age of 5 to 12, with a peak age of 6 to 7 years. But in this our particular outbreak, we've seen cases of patients that are even adults. And so but we've not recorded any case of a child that is less than 6 months, and that we attributed to most likely maternal immunity. Most of the adults that come into diphtheria have also as well other comorbidities such as diabetes, hypertension. Females there's a little bit of female preponderance among the adults, and we attributed that to me most likely because females are the carer of children and they are in the more close proximity to index cases of suspected diphtheria. And at the same time, there's high mortality among adults, male above the age of 40 years. And this is attributed to comorbidities that they do come up with, such as hypertension, diabetes, and as such, this will lead to a late presentation as well, and such this lead to long morbidity and mortality among this particular age group and sex. The commonest cause of so far we've managed more than 18,000 cases of diphtheria, and we've seen more than 1,000 cases of diphtheria coming with neuropathy. Presently, the diphtheria treatment center is seeing an average of 50 to 70 cases, new cases per week. We observed 2 waves in the course of this outbreak. The first wave was around February 2023, while the second wave that we observed was in July. And during the time that we had the wave, there was a spike in the, it rose to almost about 1,000 cases per week. And at the beginning of the outbreak, we had a very, the case fatality rate was as high as 40%, but now the case fatality rate is about less than 4%. And this is attributable to increased surveillance of awareness, the improvement in terms of vaccination coverage that have been ongoing in the state through mass active vaccination. And also, it's also could be attributed improvement in the expertise of the team that have been managing these cases over the course of almost 15 months in this outbreak. The commonest presentation of cases that we've been seeing is those that present with throat pseudomembrane as well as cutaneous diphtheria. So we notice that those that come with both throat pseudomembrane and cutaneous diphtheria tend to have a long morbidity, but does not really show whether it's going to increase their mortality. Some of the things that were observed to happen to increase the mortality are the present is late presentation, as I said, the absence of lack of adults, and even lack of injectable microlights. At the beginning of the outbreak, we were using penicillins, and then there was not very good outcome. But based on the ASD antibiogram study that was done, it was shown that the Corynebacterium diphtheria that was causing this particular outbreak in Kano seemed to be resistant to the penicillin. So we had to change the antibiotics to quinolones, and since then it has been a game changer for us. Also, the presence of complications, the most important complication we notice among our patients, acute kidney injury, myocarditis, thrombocytopenia, and on long term, we have polyneuropathies. We notice that cases that present with only one form of complications, if a patient presents with only AKI or thrombocytopenia, it tends to have a better prognosis than a patient presenting with two or more complications, or if a patient is also presenting with diphtheria or with other comorbidities like sickle cell disease or diphtheria or any other vaccine preventable diseases. Our DTC has we have a triage area where we triage and we do patient placement according to severity, and also give a first aid before then we have a ward. We also have an ICU. We have also a comorbid ward as well. And by the comorbid ward, I mean patient presenting with pertussis and diphtheria, or diphtheria with measles, because we are also having cases of pertussis now and measles in our facility. And so they are separated from those patients that only have diphtheria, so that there will be no increase in hospital spread, and so in form of IPC measures that we put in place. Another thing that we notice is that recently we have seen a downward trend in the outbreak. We are seeing about 50 to 70 cases per week, and this we hope the trend continues on this level. But unfortunately, we've already reached community level. There is no any region within the state that diphtheria has not been reported so far. So we are still not out of the tunnel, but we are hoping with improved surveillance, health promotion, and education of the populace, and also continue reactive mass vaccination, we will soon be out of the quagmire. It was a learning process for us. We've done, we have made a lot of improvisation, like the use of hydrogen peroxide gargle has been a game changer. It has abolished the need for us to even use to go for tracheostomy. So I think I will like to make a pause and stop here. And I wish you for a successful webinar. Thank you for giving me that opportunity to share a little bit of my experience about diphtheria from my region. Thank you very much. Have a nice day.
Thanks very much, Steve, for sharing the experiences from Dr. Salma. As you can see, she was very specific about the challenges that they faced and how they went around it. And Steve, would you like to say a little further about that before I invite Dr. Srini to speak?
Oh, no, look, I think it's an amazing presentation. Obviously, we've been very privileged to have Dr. Summer as part of our team and helping with the guidelines with such recent experience, both at the clinical level and also managing what was a sort of relatively catastrophic outbreak and all the learnings that had from there. So I think she's very generous with the time today to come up with the talk today and also to contribute to the guidelines. So just thanks to her and everyone else who's contributed to this work. Thank you.
Thank you very much. And now I'd like to invite Professor Srinivas Murthy, who was the chair of the Guideline Development Group, to talk about the key highlights, so to say, of this first WHO diphtheria clinical management guidelines.
Thanks, and I hope that everybody can see my slides. It's a privilege to be here to talk to people about this topic, as Steve said, which we shouldn't really be talking about, namely the clinical management of a disease that we have a good vaccine for. I'll speak for the next maybe 8 to 12 minutes or so on diphtheria, and we'll talk about some questions afterwards. I see some great questions in the Q&A box emerging, so continue to put those in there. Just for everybody to get to a common place as to what diphtheria is. As most people know, it's an infection caused by the toxigenic strain of that bacteria called Corynebacterium diphtheria. It's transmitted primarily by respiratory droplets or close contacts with respiratory secretions or sometimes infected skin lesions. And we'll talk about cutaneous diphtheria in a couple of slides with an incubation period somewhere between 2 to 5 days. It has a varied presentation, as Dr. Salma mentioned. She saw all sorts of different patients during this most recent West African outbreaks, but typically pharyngitis, nasopharyngitis, and upper airway syndromes mostly. The most unique feature of diphtheria is this firmly adherent pseudomembrane, which tends to live over the tonsils, the pharynx, the larynx, and or the nares. I'll show you some pictures of that in an upcoming slide. In terms of pathogenesis, and I apologize for the blurriness, this is from a paper from about 10 years ago, it's largely toxin mediated. And so the bacterium itself tends to be transmitted. And if it's a toxigenic strain, that toxin can spread systemically through your blood and cause a variety of syndromes, and also cause local damage. And the local damage is the things like the pseudomembrane, the pharyngitis, and other things like that caused by that toxin. The toxin can also spread, causing myocardial problems, peripheral neuropathies, and so on. It's a common respiratory pathogen, non-toxigenic strains, but disease, as we know, is in toxigenic strains. And I talked about the upper respiratory symptoms and the pseudomembrane expansion, which is the primary cause that leads to airway obstruction and death. And so the pseudomembrane itself, which tends to obstruct the upper airway, causes the symptoms of severe disease. If you look at long-term complications, and this is from a case series from about a few years ago, we see that there are long-term sequelae for survivors. Neuropathy is common, as Dr. Salma mentioned, cardiac symptoms, and so myocarditis is also reasonably common, and then just generalized weakness and weight loss, which can tend to persist in upwards of a quarter of patients after the acute infection has resolved. There are reported cases, not common, of sudden cardiac deaths post-acute infection for diphtheria, and so it's something to keep on people's radar. Also, acute kidney injury is a known complication. This is a great paper from a couple of years ago, which walks through the natural history and the treated history of diphtheria infection and goes through various models. And we leaned on this heavily during the guideline development process to determine sort of what's the rate of death, what's the rate of complications based on a systematic review of all patients of diphtheria across a bunch of different outbreaks across the world. If you look at this sort of tree, I guess, you see patients with unvaccinated diphtheria, about 70% of them, of unvaccinated patients, you see about 70% of them start to develop symptoms, that prodromal state, of which about 80% develop membranous diphtheria, which is the pseudomembrane developing on the back of the throat. And about of those, and case fatality rates range from 5 to 50%, lead to death. Some patients obviously develop recovery from the membranous diphtheria. Some patients recover directly from that prodromal state, namely don't develop the pseudomembrane, and that proportion that develop no membranous diphtheria and have asymptomatic carriage is obviously much, much, much higher in the vaccinated cohort compared to the unvaccinated cohort. This is an exquisitely vaccine-preventable disease, as we've seen in many parts of the world, and even during outbreaks, that the best tool to prevent the outbreak from spreading is effective vaccination. This is from that same paper where they go into case fatality rates that they've modeled based on different features and parameters from previous outbreaks, not including the most recent West African outbreak because it was published before then. And you see for age, case fatality is highest in the youngest age range, and that's due to a variety of different reasons, sometimes due to difficulty in managing these patients, sometimes due to delays in case presentation, and sometimes due to pre-existing immunity. You see antitoxin treatment in the second panel, with no antitoxin being associated with a substantially higher rate of case fatality compared to the provision of antitoxin. That's why that formed the crux of one of our recommendations, which we'll get to. Antitoxin treatment delay also being a substantial impact on case fatality. The longer it takes to get antitoxin, the more likely a patient is to die. And obviously, as we've discussed, vaccination. Those who are vaccinated have an exquisitely small case fatality rate. It's not zero, obviously, but it's as close to zero as you can envision, necessitating the importance of vaccination once again. Cutaneous diphtheria, we won't talk to that much. This is a classic picture of a lesion from cutaneous diphtheria caused by local disease. Respiratory diphtheria is what we'll mostly speak to, and this is a picture of the pseudomembranes that have adhered to the back of this child's throat. This is the bull neck feature, or the massive lymphadenopathy that's seen. And these are fairly prototypical for acute diphtheria. And are pictures that you don't want to see as a clinician because obviously these are intimidating and hard to manage sometimes. And so just for folks to think about and reflect on if they see a patient who's something like this, to consider diphtheria. Presenting symptoms, this is from that same case series from a couple of years ago for patients with diphtheria. 85% will have fever, and so fever is common, difficulty swallowing. And then a third or so will have that pseudomembrane with gross lymphadenopathy or so. And so it's not necessarily in all patients the pseudomembrane will be there, as discussed in that previous True Love paper. This is my personal major experience with diphtheria. Was in the Cox's Bazar outbreak in Bangladesh in 2018, 2019, and this is the epi curve of this outbreak. You see that rapid upswing and that slower tail of an outbreak, largely due to the effectiveness of vaccination at bringing that tail of the outbreak down. And it took a long time to get it down back to close to zero. But that's through the hard work of a great amount of public health teams to vaccinate a huge community in a complex environment. But that rapid upswing obviously led to a large amount of work clinically in diphtheria treatment centers. Okay, so what is the management principles? You have a patient with diphtheria. The principles are sort of fairly simple when you boil them down. They're to give antibiotics to kill the bacteria, to give antitoxin, to neutralize the toxin that the bacteria are producing. Obviously, important is supportive care, and then the surrounding tracing of contacts for vaccination and post-exposure prophylaxis. And those 4 pillars of diphtheria management remain and sort of form the basis of a lot of the guidelines that we discussed. This is a poster that was often placed in many clinics about clinical warning signs, about supportive care and how you give diphtheria. And so these are some classic clinical warning signs for diphtheria. So things like stridor, respiratory rate, chest and drawing, restlessness, bull neck. And then the other sort of systemic things like capillary refill and heart rates and cyanosis. And that leads clinicians to sort of expedite their treatment, specifically in the administration of antitoxin. As Steve mentioned, antitoxin is not always accessible, and it's a huge public health priority to make sure it's as available as possible in the places that need it for the patients that need it. This is a schematic that we used in various outbreaks about how to manage airways. This is obviously not an airway talk. I'm an intensive care unit doctor, but it's not something we can talk about here with any sort of great detail, but we will sort of bring more detail to this in subsequent rounds of guideline recommendations. So what did we come up with? And this is the guidelines that are in the chat. And thank you, Supriya, for posting those. They were made public last month. And this is the first round of recommendations from this great guideline development group. These principles: antibiotics, DAT, supportive care, and tracing of contacts. So for antibiotics, in patients with suspected or confirmed diphtheria, the WHO recommends using macrolides, azithro or erythro, in preference to penicillin antibiotics. This was a strong recommendation based on low certainty evidence. Obviously, we wished we had good, high-quality randomized evidence to inform this, but the guideline group largely came to this, one, because of the resistance patterns that are emerging around the world for penicillins, particularly in places where rapid access to susceptibility testing is not available. Giving the macrolide, where there's more confidence in the resistance pattern, was recommended. Additionally, the feasibility of giving a patient a macrolide rather than a frequent dose of an IV penicillin was an important criteria for the GDG in making this recommendation. One of the remarks is that antibiotics should be administered alongside the DAT and should not be delayed. For the DAT, which is sort of a crucial recommendation. And folks who have worked in diphtheria outbreaks in the past know that sometimes giving DAT and getting DAT can be a complex thing. Giving DAT, specifically, one of the historical aspects of giving DAT is to perform a routine sensitivity test to make sure that the patient is not going to have an allergic reaction to the administration of antitoxin. And this was a historical thing that people have been doing for generations to make sure that patients are safe when they get the antitoxin. However, based on evidence that we'll review briefly now, the WHO issued a strong recommendation against performing this routine sensitivity testing before the administration of antitoxin. This was a strong recommendation based on moderate certainty evidence. It doesn't mean that clinicians shouldn't be trained in how to manage an allergic reaction, and it doesn't mean that the clinical environment shouldn't have the relevant equipment available. Allergic reactions are still possible. However, the role of the routine sensitivity testing in predicting and preventing those allergic reactions was not deemed to be important. I don't have time to go into all of the specifics of how we came to this determination, but it was through complex modeling of the role of the allergy test and how it impacted whether or not a patient would get an allergic reaction, acknowledging that the crucial part of management of diphtheria is giving the antitoxin, and that's the thing that's going to save their lives. How much antitoxin to give and who to give it to? And so this is an important criteria given the availability of data is not always available. The WHO issued a conditional recommendation for that in patients with suspected or confirmed symptomatic diphtheria. The WHO suggests administration of a single dose of diphtheria antitoxin with a choice of dose based on disease severity and the time since symptom onset in comparison with a fixed dose. And so it's not that every patient who comes to the clinic with diphtheria will get the same dose. There will be a dose gradation based on how severe the disease is and how long that patient has had the disease. Remember, the toxin is being mediated by the antitoxin, and so if the patient has had disease for a number of days, there's likely to be more toxin floating around, and will require more antitoxin to neutralize. Similarly, with very severe disease, those patients will require more antitoxin to neutralize that. One of those remarks is that the DAP must be administered as soon as possible. I showed you that case fatality rate slide where delays in antitoxin lead to increases in morbidity and mortality. And so it's important that patients who have suspected or confirmed symptomatic diphtheria, that antitoxin is administered as soon as possible. These are the dosing recommendations for the dose of antitoxin to receive, and this is for different criteria of diseases, namely laryngitis or upper airway disease exclusively, and a smaller dose if you have extensive pseudomembranes across the nasopharynx, a medium-sized dose, and if you have more severe disease, systemic disease specifically, then you get the largest dose, which is 80,000. And this is through the historical evidence about antitoxin use, as well as some modeling data as to the role of antitoxin in various different disease characteristics. Supportive care and tracing of contacts for vaccination and post-exposure prophylaxis is sort of the next wave of the recommendations that are emerging. As Steve mentioned, there's lots of requests to make sure that we have good quality evidence for diphtheria during outbreaks, and providing high quality supportive care and making sure that people around infected individuals get the care they need are important next steps for this guideline group. And so upcoming recommendations that are emerging is, should close contacts receive antibiotic prophylaxis? How long do contacts receive prophylaxis for? How long should the infected be isolated? And then some supportive care strategies. What is that optimal early airway management strategy for patients with symptomatic diphtheria? Does it differ by children? Does it differ by how extensive the pseudomembrane is, and so on? These are upcoming, and we look forward to disseminating those to this community when those emerge also. I'll stop there, and thank you for that. It's been a pleasure to work with everyone at the WHO and work with everyone in the larger community to produce these guidelines, and hopefully they're useful for the larger community to inform care. Thank you.
Thank you very much, Professor Murthy, and thank you for your leadership in developing the guidelines. We will now go on to Q&A, but before we do that, I'd like to invite Janet Diaz, if you'd like to say a few words. Janet is the lead for this unit in WHO.
Hi, Supriya, and thank you. I don't really want to take too much time, other than the presentations were outstanding, and I could see that many of the audience was very engaged in that. So thanks so much, everyone, for all that feedback. Just the importance of having high quality, transparent, trustworthy clinical practice guidelines to manage patients is really important. But now the key is that the participants here, those of you that are taking care of patients, that you implement these guidelines. So how best can we get this information out there? This is one way to get the information out there. The other way, obviously, it's on our website in the PDF format. We also have a electronic platform called the Magic app, where you can see the guideline in electronic and an e-platform type of dissemination approach. So we have multiple ways that we're trying to get that information out there. Also updated our training modules on openwho.org. So you can see the updated modules there with these new recommendations, but really it is trying to get it out there and get these information shared to the clinicians so they can best treat their patients. So thanks, Supriya, and over to you, and thanks so much for this.
Thanks, Janet, and thanks to Steve, Srivi, and of course, Dr. Salma for the presentations, but thanks especially to everyone who's asked questions. We have quite a few here. Steve, would you like to the first question we have here is about suspected diphtheria definition. why some countries use the presence of pseudomembrane as a criteria in the definition of suspected diphtheria and some not, and can it be uniform all over? I throw it to both of you. Any questions about uniform definitions?
Shireen, do you want to?
Yeah, it's a hard one because case definitions are so important during outbreaks, and sometimes they are uniform and sometimes they have to adapt given sort of the available resources. And some case definitions require microbiologic confirmation in some regions, and some case definitions require clinical disease exclusively. In the absence of pseudomembrane, it's going to be very hard. In the absence of pseudomembrane or a microbiologic test, it's obviously going to be very, very hard to diagnose diphtheria in any sort of confident way. So that being said, a lot of it's dependent on available resources and the scale of an outbreak at times. And so case definitions may vary as outbreaks vary.
Thank you. Steve, anything to add there?
I think just adding, as Shrin said in his talk, obviously lab facilities are limited and takes time. So really just emphasising to people again that in a case of diphtheria, it can be a clinical diagnosis and treatment initiation as soon as possible, hopefully if it's available. It's the key thing, because as we demonstrated, the patient's survival depends on, it's dramatically increased if we can get the treatment to them as rapidly as possible. Thanks.
Thank you. We have now I'm just going by order of which the questions were asked, but Steve, you've had a look at the questions. If there's any specific one that you would like to answer first, please go ahead. And also I know we are getting to the end of the hour, but I think considering how interesting and important this is, if it's okay with everyone, we can continue with the Q&A for a little longer.
Sure.
So
I think yeah, the second question is interesting, and I think we've tried to type into some answers while we're going. We're probably a little bit slow on typing, both Shrin and I, but we're getting there. But the second question is the reason of high variation in CFR in different countries, and I think that's a good question. Obviously hard to answer with a simple answer. The person who's written the question that says, is it a denominator issue? There probably is an issue of the true diagnostic rate of diphtheria, because there would be mild cases that I assume aren't picked up, or especially in vaccinated patients. But we know the variation in CFR. We know the factors that go into the person's mortality. So we know the early treatment is the controllable factor. Then we get the person antibiotics and antitoxin as rapidly as possible. We know that in many conditions, and diphtheria would be no different, can we provide the level of supportive care the patient needs? And that's obviously a challenge in many places, especially when you hear Dr. Salma talk about hundreds of patients of coming in a day. Being able to facilitate supportive care is obviously challenging, and the time that's available to that. I think in isolated cases, obviously we see a high CFR, the risk is missed diagnosis. In many places of the world, as I think you mentioned in your introduction, it's a disease that not many people have seen in many parts of the world. So there's also many reports, anecdotal and other, of people missing the diagnosis, especially early in outbreaks, which obviously is entirely understandable, but something we could obviously work towards. So I think early recognition and treatment, and then the ability in the facilities to try treatment. And I noticed someone else put into the chat that diphtheria antitoxin is very limited in many settings, which it is. There's clearly not enough, and we're obviously advocating very highly for more DAT, and obviously to get it obviously to patients, not just produced. Anything to add, Shrin?
Nope.
Just seeing if there's any other questions that I can throw at Shrin that would be good.
There's one on what number of suspected cases signifies an outbreak.
So this is a EPI question. And there are varying definitions as to what is an outbreak and so on. And so I don't want to get in trouble by answering the wrong answer. So I will say, I will defer that one.
Yeah.
Okay. Steve, would you like to answer that, or we can get back to the person with an answer?
Look, it's a very fair point. I know, look, our colleagues at WHO have worked on a lab guideline for outbreak settings, which is a really valuable document as well, and worth looking at if you have an interest in that area. Now, that's not trying to diagnose what's an outbreak, but it is providing at least some guidance, because one of the problems we saw is that many of the guidance around the world understandably, was written for isolated cases that might be breakthroughs, and obviously lab facilities and efforts are quite different in that situation when you have hundreds of cases coming in. So there is now some WHO guidance around what to do for outbreaks in terms of lab-based testing. How many people would you recommend testing for? What do you do with the results of the test? And it's not an area I'm got great expertise in, but it's a really useful document for people to use as well.
There's a question also, I mean, this is not on clinical management, but it's on supplementary immunization activities, outreach program for diphtheria, and how your team managed this challenge. I was just wondering, Shrin, would you like to comment on that from your experiences in Cox's Bazar, perhaps? Or
Yeah, and not just there, but everywhere, I guess. This is the big challenge, making sure that during an outbreak, you can convince a community of the importance of vaccination, of immunization, of diphtheria. And that requires true community leadership, engagement, and many things that folks on this call are probably experts on in their local environments. And so I think a lot of that is, one, accessibility to the immunizations, but two, more importantly, engagement with the communities to make sure that they have trust to get those immunizations during those outbreaks. And so I think there are many challenges. That's a whole separate webinar about mass immunization campaigns that we don't have time to get into now.
Great, thank you. I see that people are writing questions on the chat. Could you please add it to the Q&A, because there's so much on the chat that we might miss your questions there. Go on to the next question. I mean, they're both EPI related. If you'd like to take it, have other countries seen an increase in cutaneous disease, and what are the typical locations and epidemiology? And
we made a decision with our guideline to not focus on cutaneous disease, rightly or wrongly,
okay.
from an urgency point of view. So we have, as part of the literature reviews and all the things that were done, it obviously came up, and there is some speaking on the back of that, but obviously with less time was dedicated to that. It does face some of the similar problems, cutaneous disease, and the lack of research. And one thing probably worth highlighting now, and I know our colleagues in Nigeria are working hard on this at the moment, is and one of the reasons we probably pause over some of these answers and don't provide as much detail as we'd like is there really is a lack of research in diphtheria. It's a neglected disease in more ways than just the treatment. So one of the disappointing things about writing the guideline was looking back through the literature and seeing very few, if not any, even high quality observational data was very limited. Now, people have done some great work in the field to report their experience during outbreaks and other things, but you wouldn't, they're not, unfortunately, there's not a lot of literature that is enough to guide future recommendations. There's certainly no randomized trials of different treatments or different options and paradigms. For a disease with such a high CFR, obviously affecting children and vulnerable members of the community, that was a pretty disappointing outcome. And I guess one of our things we're advocating for moving forward is that when outbreaks do occur, if they do, unfortunately, then we could try and do some prospective, even just observational research, even just to try and get a clearer picture of what happens. And I think Dr. Salma said it best. They did some great work in Nigeria to try and work out what was the risk factors for people that didn't do well. But can we be even more proactive? And because then once we do that, then we can start building on that some more research that might actually look at improving the outcome of patients as quickly as possible. So that's one of the things, and that plays into the cutaneous as well. I think there's very little data to drive any of these recommendations in terms of high quality evidence. And you would have seen that with Shrin with his presentation when we had to make recommendations, but the quality of the evidence was pretty consistently low.
Right. Another question we have is on the symptoms. Should development of pseudomembrane be waited before reporting cases to the authorities for sampling and public health response? Or is fever, dysphagia, anterior cervical swelling, and suspicion of diphtheria, is that enough?
Shrin, do you want to?
Yeah, so the pseudomembrane it depends on the context once again. And so if there's no outbreak declared, a pseudomembrane will be required to sort of identify a patient as having diphtheria. If there is a massive outbreak with lots of patients having pseudomembranes and other patients with confirmed diphtheria already floating around in that community, then whether or not the pseudomembrane is required to make a sort of a clinical diagnosis of suspected diphtheria that's early is less convincing. And so it's more likely to be a diphtheria case in the context of an outbreak than not. So do you need a pseudomembrane? You do in the context of a non-outbreak setting. And I put in the chat for one of the answers that WHO diphtheria outbreak toolbox, which goes into a lot of these features and a lot of these considerations during outbreaks and case classifications and all the rest. And folks can review that.
Thank you very much. We do have some other questions as well, but we are over time, and I know both of you also have other commitments. So I think we will stop here, and if possible, we'll try and respond to these questions by email in future, and let's see what we can do to make sure that most of these questions are addressed. We'll do our best. But I'd like to thank everyone. First of all the participants for your engagement, really appreciate it. And then, of course, the panelists, thank you very much. I'd like to say that Steve is right now in Australia, where it's well past 10 o'clock. And Srinivas are you in Toronto? Where it's also very early morning. Yeah. It's what, 6 o'clock, 7 o'clock? So thank you very much for joining, nevertheless, in spite of the time challenges. I really appreciate it. And it's been very useful. Congratulations to you and to the entire team and to Janet for developing the first WHO clinical management guidelines for diphtheria. And I'm sure it'll be very useful. As we see, the majority of the participants here do not have experience of response to diphtheria outbreaks, but they are interested, which goes to show that this will be very useful, these guidelines for, making others familiar with the key issues. I'd also like to thank those who've been behind the scenes. Brian Yao, who I've troubled since this morning to help out, especially with tech issues in Zoom, because I have to admit I am not tech savvy at all. And Mim, who's Prichaya Shritep, who's been managing the chat and communicating with all of you. And of course, our IT department, who was very helpful this morning, especially in trying to get Dr. Salma's video across. And last but not least, Dr. Janet Diaz. Thank you very much, Janet. And it's always a pleasure to collaborate with the clinical management team, the wonderful work you do. And with that, we will have more EPI-WIN webinars at the end of April, tentatively 18th April. We will have one on community-centered readiness, operational readiness. And we have some others planned, and you will hear from us soon. But look forward to hearing from you as well, and have a great weekend. And for those of you who mark Easter, have a wonderful Easter weekend as well. Bye.
Thanks very much.
I've also